I'm Dr. Fakir Avadi, and this is Opportunistic Infections in Adults. Opportunistic infections typically do not affect patients with an intact immune system, so the name opportunistic refers to the fact that these infections take advantage of immunocompromised patients. Immunocompromised patients not only can they get opportunistic infections, but they can also have non-opportunistic infections like other people. So infections like UTIs, community-acquired pneumonia, skin and soft tissue infections, etc. Which patients are considered immunocompromised? In general, advanced HIV, meaning a CD4 cell count of less than 200, as well as cancer patients receiving chemotherapy that cause myelosuppression, including neutropenia, and those patients who receive immunosuppressant therapy for either autoimmune conditions, as well as those who have received transplant, and that includes both solid organ transplant as well as stem cell transplant. And one thing that's very important to keep in mind is that use of systemic corticosteroids at a dose equivalent to prednisone 20 milligram per day or more for at least 4 weeks is considered immunosuppression because that can affect the T cells. And asplenia. So the spleen has the function of filtering the blood. So specifically, any bacteria that's encapsulated will be removed by the spleen. So that includes pneumococcal species as well as Haemophilus influenzae. And asplenia could be either functional asplenia, for example, patients with sickle cell disease will have a non-functioning spleen, or if it's anatomical, meaning that it was surgically removed, so splenectomy. In this topic, we will focus on HIV-related opportunistic infections, which are those infections that are most frequent or more severe because of HIV-mediated immunosuppression. Now, in general, for patients who are linked to care and who manifest durable responses to long-term ART, survival of patients with HIV infection is currently almost equal to that of individuals without HIV infection. So, in general, these are basically becoming rare in patients with HIV because we have very effective ART. Now, one thing to keep in mind is that HIV-related opportunistic infections do not behave clinically exactly like opportunistic infections seen in other immunosuppressed population. For example, when we talk about toxoplasmosis in HIV, toxoplasmosis manifests mainly as encephalitis, whereas in patients with cancer or organ transplant, for example, it's more likely to be like visceral or disseminated disease. We're also going to talk about Pneumocystis Pneumonia, which is far more likely in patients with HIV. Yet the same organism often develops indolent disease in other immunosuppressed patients. So here's the problem in advanced HIV. So obviously a normal person has a large amount of CD4 cells. So here on the y-axis we're looking at concentration of CD4 cell count in the blood, and on the x-axis we're looking at time. So a normal person has very high number of cells, CD4 cells in the blood, and once this person gets a primary HIV infection, then these CD4 cells start to go down, and then as time goes on, and this is of course without ART, these CD4 cells start to go down in time, and then by the time it hits less than 350, this is where the risk of some infections go high, including some viral infection like varicella zoster, as well as other bacterial infections at tuberculosis. So these infections occur more frequently. Now these are not necessarily opportunistic, but the rate goes up. Now once you hit the the 200 mark. So if the CD4 is less than 200, that's when the risk of opportunistic infections becomes real. So this is when you get pneumocystis pneumonia, esophageal candidiasis, and then as the CD4 goes even lower, so less than 100, then the number of opportunistic infections go up. So you started to have more incidents of cocci, crypto, as well as toxoplasmosis and mycobacterium avium complex. So for someone with CD4 cell count very low, specifically less than 200, the immune system is essentially non-existent. And now imagine an HIV patient who starts ART. So if the CD4 count is depleted and then they start ART, then CD4 can start to go up. Now this can result in a syndrome referred to as IRIS. So IRIS stands for immune reconstitution inflammatory syndrome, and this basically means that if you start ART and CD4 cell count goes up, then you start to have symptoms of inflammation. And that's because previously, because of the lack of immune, lack of an intact immune system, the patients are not capable of having that immune response, so symptoms of inflammation are non-existent. So when you start ART and these symptoms suddenly occur, which sometimes can be very severe, this can be due to two reasons. One is referred to as unmasking iris, which is basically, if someone already had an infection, but because there couldn't be an immune response to it, obviously there wouldn't be any symptoms. And once you start ART, then those symptoms basically become unmasked. So this is referred to as unmasking iris, that you just discovered an infection that was already in the patient. We just didn't know about it because of lack of symptoms. Another one is called paradoxical iris. And this is basically in someone who used to have an infection, but the infection is not necessarily there anymore. But the residual antigens from that previously resolved infection might be circulating in the body, and once you start ART and these CD4 cell counts go up, the body will have a response to it. So these are important to keep in mind in someone with CD4 less than 200. Once we start treatment of opportunistic infections, if you start ART at the same time, for some infection, initially it may look like the patient is getting worse, even though you just started ART. And that's typically not a concern because it's just iris happening. Now, I say typically there are situations where the iris can be severe, specifically when it comes to CNS infections. So, sometimes it might be necessary to actually treat iris with anti-inflammatory agents like corticosteroids. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for opportunistic infections. So trimsulfa, trimethoprim, sulfamethoxazole combination is by far the most commonly used agent. There are two brand names for it, Bactrim or Septra. And it's available as PO and IV. Most commonly it is used as PO. The IV formulation has very limited stability. So, if you can use PO is used more often. And the adverse profile, you can see that obviously these happen at the same time because trimsulfa is given often as a combination. Trimethoprim is also available as a standalone drug, but more commonly it's used in combination. So trimethoprim component can lead to anemia, leukopenia, thrombocytopenia, as well as hyperkalemia and hyponatremia. Trimethoprim can also inhibit the secretion of serum creatinine, so it can artificially increase serum creatinine levels without affecting GFR. So that's just an artificial. But the most important is really to keep an eye on the hyperkalemia when it comes to monitoring of trimethoprim. other adverse effects are not really as common for trimethoprim. For sulfamethoxazole, it's a sulfonamide, and for sulfonamide drugs in general, you want to think about skin reactions. So rash is the most common one, and sometimes it can be severe. So Steven-Johnson syndrome can happen. It's rare, but it can be fatal. And other skin-related reactions include photosensitivity. And in addition, sulfonamides can also have GI adverse effects, so nausea, vomiting, and diarrhea. And they can also be nephrotoxicity. So together, trimethoprim and sulfamethoxazole, really can cause nephrotoxicity, and this could be a combination of sulfonamide causing nephrotoxicity as well as trimethoprim artificially inhibiting the secretion of serum creatinine. You do need to renally adjust the dose of trimsulfa. So if creatine clearance is less than 30, half of the dose should be given. We also have sulfadiazine, which is also sulfonamide, so it's very similar to sulfamethoxazole. And we also have dapsone, which is similar to sulfonamides. Now, dapsone can cause methemoglobinemia and hemolysis, especially in patients with G6 phosphate, glucose 6 phosphate dehydrogenase deficiency. So it is recommended to test patients for glucose 6 phosphate dehydrogenase deficiency, and if they have that deficiency, it's best to avoid dapsone. Atovaquone inhibits ATP production by inhibiting the mitochondrial electron transport chain. It is very important to take this atovaquone with food in order to increase absorption. Now, we also have a couple of anti-malarial drugs that are used for opportunistic infections, so primaquine and pyrimethamine. And primaquine is actually contraindicated in patients with glucose 6-phosphate dehydrogenase deficiency, so it's absolutely essential to test patients for this deficiency before we start. And then leucovorin is basically a folic acid vitamin, which is used in combination with pyrimethamine in order to avoid the adverse effects, specifically hematologic adverse effects of this drug. So leucovorin technically is not an antibiotic. It doesn't do anything to opportunistic infections. It has to be given with pyrimethamine to basically avoid the severe adverse effects of that drug. And lastly, we have pentamidine, which is also available in an inhalation formulation, but it is not available as an oral formulation. Now let's take a look at some of the antiviral agents used for management of opportunistic infections. And here we're really talking about cytomegalovirus, or CMV, as the opportunistic viral infection. And because acyclovir, valacyclovir, and famciclovir are ineffective against CMV, we're not going to talk about them. The most common antiviral agent used for management of CMV is ganciclovir. And ganciclovir is basically a nucleotide analog, so it inhibits viral DNA synthesis. It has very poor oral bioavailability, so the oral formulation is no longer available in the US. It's primarily used as an intravenous injection. It can also be injected into the eye. Now, valganciclovir is basically a prodrug of ganciclovir, and this addition of valine group improves oral bioavailability. So it is available as PO, and it must be taken with food to increase absorption. And once it's absorbed, it's basically converted to ganciclovir. So mechanism of action is identical, as well as the adverse effects. Unfortunately, these agents are very toxic. The most important toxicity of these agents is myelosuppression, and this is dose limiting. So patients basically will experience neutropenia and thrombocytopenia, so platelets will drop. Now, fortunately, this is reversible, so within 1 week of drug cessation, neutropenia should be resolved. There's also GI effects, so nausea and vomiting, as well as CNS effects, headache, insomnia, and it can be severe. So seizures and coma have also happened in patients, but is not as common. They can also cause hepatotoxicity. This is, mild elevation of liver enzymes. Is not as severe as CNS effects and myelosuppression. Some patients can experience fever, rash, anemia, and peripheral neuropathy. Now, Cidofovir is also a nucleotide analog, and it's only available as IV because of poor oral bioavailability. Now, this agent is not causing as much myelosuppression as ganciclovir, but it is extremely nephrotoxic. In fact, it is the most nephrotoxic agent used for CMV. It is so nephrotoxic that initiation of Cidofovir therapy is actually contraindicated in patients with existing renal insufficiency. And it must be administered with high doses of probenecid in order to block active tubular secretion and decrease nephrotoxicity. And before each infusion, Cidofovir dosage must be adjusted for alteration in creatinine clearance or for the presence of urine protein, and aggressive adjunctive hydration is required. So normal saline would be administered before and after the infusion to reduce nephrotoxicity. Cidofovir can also cause anterior uveitis. So basically, this is inflammation in the uveal layers in the eye, and anterior means that this will be in the front of the eye as opposed to in the posterior area. Now let's take a look at foscarnet. So foscarnet is an inorganic pyrophosphate analog, so it is not a nucleotide analog, so the mechanism is very different. So when it comes to cross resistance, this becomes very important. But it does inhibit viral DNA synthesis, so the end product is the same. And it also has poor oral bioavailability, so it's only available as IV, and it can be also injected into the eye. It is also very nephrotoxic, so it's not as nephrotoxic as Cidofovir, but it's very nephrotoxic, so it can cause a lot of electrolyte imbalances. So calcium can either go up or low. So, hyper or hypocalcemia can occur. It just depends. The same with phosphate. So, hyper or hypo, whereas magnesium and potassium will often be low. So, hypokalemia and hypomagnesemia. It can also cause GI effects, so nausea and vomiting, and some CNS effects, including seizures, some mild elevation of liver enzymes, as well as some, anemia, fatigue, rash, and leukopenia. But it's not, the leukopenia is not as severe as myelosuppression caused by ganciclovir and valganciclovir. Now, because of this severe nephrotoxicity of foscarnet, saline preloading is also recommended to prevent nephrotoxicity. So normal saline is often given before the infusion. Lastly, we have letermovir that was recently approved, and it is only indicated for prophylaxis in CMV seropositive recipients of hematopoietic stem cell transplant. So it is currently not indicated for patients living with HIV. But I put it here in case in the future it gets approved for use in HIV patients as well. The mechanism is different. So it is an inhibitor of DNA terminase complex. And this is something that's very unique to the virus, to CMV. So basically, because mammalian cells do not have this, there is very minimal adverse effects from letermovir. So it is generally well tolerated. Of course, there can be some GI effects like nausea and vomiting, and it is available as both IV and PO. Now, when it comes to the life cycle of CMV, which is a DNA virus, it basically has to enter the nucleus of the host cell. And once it goes into the nucleus, it needs to do two things. So it needs to do the usual, conversion from DNA to messenger RNA, and then, through translation, have some final products, proteins that are used by the virus in order to make more virus. But also the DNA needs to replicate. so multiple copies of the DNA, and this DNA will also be used with these proteins in order to assemble a new variant and then release it, and the cycle continues. So this, because the synthesis of DNA is important for replication, this is targeted with our antivirals. So the antivirals that we have, now here we have a general figure, so acyclovir and famciclovir are listed, so that's really more pertaining to herpes simplex virus. But for CMV, it's really ganciclovir and valganciclovir that basically act and inhibit conversion from a nucleoside to monophosphate nucleoside. So this is a phosphorylation process that's required for DNA synthesis. So all nucleotides needs to be phosphorylated as part of DNA synthesis. And these agents that are listed here need to be phosphorylated in order to mimic this phosphorylated nucleotide. And these agents are actually phosphorylated by virus-specific enzymes. In the case of herpes simplex virus, is thymidine kinase. In the case of CMV, it's a protein called UL97. So it's UL97 that will phosphorylate ganciclovir, and then ganciclovir phosphorylated by UL97 will be able to block this step. Now, this is monophosphorylated. It will continue to be phosphorylated to diphosphate nucleotide, and this is the step that's blocked by Cidofovir. So Cidofovir is different because it doesn't need UL97. So if there are mutations in UL97 leading to ganciclovir resistant CMV, Cidofovir will continue to have activity against ganciclovir resistant CMV if the mechanism is mutations in UL97. If the reason for resistance is mutation in the DNA polymerase used here, Cidofovir will also be resistant. So mutations in polymerase will cause resistance to ganciclovir and Cidofovir, and that's where foscarnet comes in. So foscarnet can block the final step. So really foscarnet's use is for those resistant strains of CMV where ganciclovir and Cidofovir are no longer viable. Here are the black box warnings for Cidofovir. So of course, renal impairment, and there are recommendations from the FDA to reduce the possibility of nephrotoxicity. They also have neutropenia as a black box warning, as well as carcinogenic and teratogenic, and also hypospermia in men. Some of the contraindications include hypersensitivity, serum creatinine greater than 1.5, creatinine clearance less than 55, urine protein 100 or more, and use with or within 7 days of nephrotoxic agents. And these nephrotoxic agents include things like amphotericin B, aminoglycosides, NSAIDs, and also foscarnet. There are some situations where multiple antivirals can be used in combination when dealing with resistance. So there may be a situation where Cidofovir and foscarnet might be needed to be used together, but that's actually contraindicated because of the nephrotoxicity. And of course, Cidofovir should not be injected into the eye because of the toxicity to the eye. The next learning objective is explain the pathophysiology and clinical presentation of Pneumocystis Pneumonia, Toxoplasma, gondii Encephalitis, and Mycobacterium avium complex disease. Pneumocystis Pneumonia, or PCP, is actually caused by Pneumocystis jirovecii, which is actually a fungus species. So PCP, which some people call PJP because of this change in nomenclature. So it used to be, PCP, the C used to stand for Carinii, but because it was the taxonomy was changed, you may see the abbreviation PJP. But in general, the DHHH guidelines still refer to it as PCP. Now, because this is ubiquitous, it is thought that we all get exposed to this organism as a during our childhood, and immunosuppressed the patient, it basically gets reactivated, and in HIV specifically, it can lead to the infection of the lungs and pneumonia. And 90% of PCP cases occur when the CD4 cell count is less than 200. So this is an important cutoff to remember. CD4, less than 200. Also, patients who do not have HIV, but they are on prolonged use of systemic corticosteroid. So typically at least 20 equivalent milligram of prednisone for at least 4 weeks. These patients will also be at risk of PCP, because corticosteroids can also reduce the CD4 count. Now, transmission is person to person, so obviously healthy people can be colonized with this. It just doesn't cause an infection in an intact immune system, but immunodeficient people will actually develop the pneumonia. Now, when it comes to the host defenses, there is innate immunity, so alveolar macrophages as well as surfactant proteins protect individuals from this organism, as well as humoral immunity. So T cells, B cells, and immunoglobulins from the B cells are involved, which explains why patients with compromised T cell are at increased risk of getting PCP. So the clinical manifestations include exertional dyspnea as well as fever, non-productive cough, and chest discomfort, which worsens within days to weeks. Now, this is a progressive disease, so the prodromal period can extend from 3 to 8 weeks. So in general, for any infection, the initial phase is the incubation period, followed by prodromal period where you have mild signs and symptoms, and then you have a period of illness followed by a period of decline, as well as a period of convalescence. So in PCP, in HIV patients, this prodromal period could be very extended, 3 to 8 weeks. So it's very progressive. So for definitive diagnosis of PCP, histopathologic or cytopathologic demonstration of the organism is in either tissue, BAL fluid, or induced sputum sample is required. If you have chest radiograph, so technically basically chest x-ray, you will see symmetrical ground glass infiltrates. On chest CT, you will also see the same. The benefit of chest CT is that even if the chest x-ray is normal, you can still see the ground glass appearance on the chest CT. PCR is an alternative method. It's alternative because it's expensive, and it's also cannot distinguish between colonization and infection. And there's also the B-glucan test, which is highly sensitive but low specificity. So if it's positive, it doesn't necessarily mean PCP. It could be any fungal infection. But if it is negative, then you can rule out PCP. And lastly, one observation is that lactate dehydrogenase typically happens to be greater than 500 in patients with PCP, but that's non-specific. So, this is not really for diagnosis. It just gives you a clue if you see a high lactate dehydrogenase. Let's change gear to Toxoplasma gondii. So toxoplasmic encephalitis, or TE, is caused by Toxoplasma gondii. It is a protozoan parasite. So you can see that in the life cycle of this parasite, cats are involved as well as livestock. So, the risk factors for getting this would be basically undercooked meat as well as raw shellfish, so oyster, clams, etc. as well as if you have exposed vegetables, so untreated water or organic food, or if you're growing your own food and cats are even livestock are around these, that could expose the patient to Toxoplasma gondii. Now this is opportunistic infection, so people with an intact host immunity don't have to worry about this, but this is for people with CD4 count less than 200 that are at risk. So clinical manifestations include focal encephalitis with headache, confusion, or motor weakness and fever. For diagnosis, it is important for all patients with TE to be tested for Toxoplasma IgG because they will be seropositive. So Toxoplasma IgG will be positive. So if the IgG is negative, it's very unlikely that someone has toxoplasmosis. Now, definitive diagnosis requires 3 criteria. So a compatible clinical syndrome, so the symptoms have to be there, and then identification of 1 or more mass lesions by CT or MRI of the brain, as well as detection of the organism in a clinical sample, typically brain biopsy. And this is really reserved as a last resort. In other words, instead of doing brain biopsy, if someone has Toxoplasma IgG, you go ahead and treat them. It's really not necessary to go into brain biopsy. And lastly, Mycobacterium avium complex, or MAC. There are multiple species of Mycobacterium, so not Mycobacterium tuberculosis, but we'll talk about that on another day. But these are more of a slow-growing, non-tuberculous mycobacteria, which several of them that are common in these patients are grouped together and called a complex. So because avium is the most common one, gets the name. So Mycobacterium avium complex is a group of multiple mycobacteria. Regardless, these are opportunistic infections that typically occur in people with HIV with CD4 of less than 50. So this one, you really have to deplete the CD4 cell counts in order to be exposed to this. We will discuss more about mycobacteria in general when we talk about tuberculosis on another topic. Symptoms include fever, night sweats, weight loss, fatigue, diarrhea, and abdominal pain. So you will see that these symptoms are also common in tuberculosis, night sweats, weight loss, as well as anemia and elevated liver alkaline phosphorus. For diagnosis, a confirmed diagnosis is based on compatible clinical signs and symptoms, as well as isolation of MAC from culture of blood, lymph node, bone marrow, or other normally sterile tissue or body fluids. Now, cytomegalovirus is widely prevalent herpes virus. It is a double-stranded DNA, and the primary route of transmission is by interpersonal contact via infectious body fluids, including saliva, semen, cervical secretions, as well as breast milk. Now, when somebody gets infected by CMV, it establishes latent infection in the host after recovery, just like all other herpes viruses. And pretty much more than half of the population is infected with CMV. Fortunately, there is no disease in healthy hosts, so it's pretty much asymptomatic infection in healthy individuals. Now, it does cause congenital CMV syndrome in neonates, which could be fatal for neonates. And it can cause infectious mononucleosis in young adults, essentially manifesting as fever, malaise, and myalgias. Now, the real problem is when we go from CMV infection to CMV disease. So severe disease syndrome occurs in immunocompromised individuals, and that includes recipients of solid organ transplants. So solid organ includes the lung, liver, kidney, and heart, as well as recipients of hematopoietic stem cell transplant, and patients with HIV and advanced immunosuppression. Specifically, a CD4 count of less than 50 puts these individuals at risk of severe disease of CMV. Now, what exactly is CMV disease? So CMV can cause retinitis in the eyes. It can cause colitis in the GI tract, esophagitis also in the GI tract, and pneumonitis and neurologic disease. The most common in individuals with HIV is retinitis. And this really up to 30% in individuals not receiving ART. In the era when individuals are receiving ART, it's really not as common anymore. And it's followed by colitis, about 5 to 10% of individuals. And then esophagitis in a very small percentage. Pneumonitis is very uncommon. Now let's take a look at some of the symptoms. With retinitis, basically patients will experience floaters, which essentially means spots in the vision, scotoma, and the plural for scotoma is scotomata, and it essentially means a partial loss of vision or blind spot in an otherwise normal visual field, and of course peripheral visual field defects. And diagnosis is done by an ophthalmologist through eye examination. Patients with CMV colitis experience weight loss, fever, anorexia, abdominal pain, diarrhea, and malaise. And it can be severe if it causes hemorrhage and perforation, which can be life-threatening in patients. The next learning objective is given a patient living with HIV, assess the need for opportunistic infection primary prophylaxis. So primary prophylaxis basically means that the patient is at risk of getting the infection but doesn't have the infection yet. We're trying to prevent it from happening for the very first time. So for PCP specifically in HIV patient, if the CD4 count is less than 200, you need to provide the patient with PCP prophylaxis. And the preferred agent is Bactrim. So trimethoprim sulfamethoxazole, the most evidence is with one double strength PO daily for the most patients. Now, if they cannot tolerate that because of adverse effects, only then you can give them a smaller dose. So the smaller dose is likely to help with the adverse effects. In addition to CD4 count less than 200, if someone has CD4 less than 14%, as well as if somebody's CD4 is borderline, so it is above 200, but it's less than 250, and you cannot monitor the CD4 every 3 months, because of, whatever reason, so either access to care, because there's a very high chance that this patient might drop less than 200, these patients also could benefit from PCP prophylaxis. Now, in people who cannot tolerate Bactrim even with a lower dose, there are some alternatives listed here. So specifically, you can use dapsone monotherapy. However, we're going to talk about toxoplasmosis prophylaxis in a minute, but basically dapsone monotherapy does not provide prophylaxis for Toxoplasma gondii, so that's important to know. Now, if you use dapsone in combination with pyrimethamine and leucovorin, that also gives you protection against toxoplasmosis. Other options include aerosolized pentamidine, so this is an inhalation, which does not protect against toxoplasma. And then, of course, atovaquone, which must be taken with food for absorption. Now, atovaquone is actually pretty expensive. So typically, dapsone, if someone cannot tolerate Bactrim, typically dapsone would be the next option. If atovaquone is available, typically this can be cost can be a problem. And then how long do you do PCP prophylaxis? So you continue PCP prophylaxis until the patient has CD4 greater than 200 for at least 3 months. And this is obviously, if the patient is not on ART, you have to start ART in order to get the CD4 count up. Otherwise, CD4 count is not going to go up. So here are the recommendations for Toxoplasma. So in order to do prophylaxis, so the CD4 count has to be less than 200, but also you want to see Toxoplasma IgG positive. So prophylaxis is only recommended in patients with IgG positive patient. That means they have been exposed to it, so they're at risk of developing disease. And by disease, I mean specifically encephalitis. So the IgG basically tells you that they've been exposed to the organism, but they don't necessarily have encephalitis. What you're trying to do is to prevent this organism causing encephalitis. So the encephalitis part is what we're trying to prevent. So the preferred agent is also Bactrim. Just like before, you give a double strength once a day. If the patient cannot tolerate it, then a lower dose, including 3 times weekly, may be an option. And if they absolutely cannot tolerate Bactrim, then we have alternatives. So Dapsone, as I mentioned previously, Dapsone monotherapy is not appropriate. It's not effective. So it has to be Dapsone in combination. And then we have atovaquone, which has to be taken with food. So how long to do prophylaxis? So you continue prophylaxis until CD4 count is more than 200 for at least 3 months. Once the patient starts ART. And then lastly, for disseminated MAC, drug of choice are macrolides. So for MAC, you need macrolides. So azithromycin. Pay attention to the dose here. So these are large doses, but once weekly. So 1200 milligrams of azithromycin once weekly. So azithromycin is preferred for prophylaxis because it's better tolerated and less drug-drug interactions. Clarithromycin 500 milligram BID has more drug interactions. Also, it's too many pills, so you have to take it twice a day. Whereas azithromycin you do once a week, it's easier for compliance for the patient. And of course, who needs MAC prophylaxis is if the CD4 count is less than 50, and that's after ruling out active disseminated MAC. And it has to be not on fully suppressive ART. So this is a new recommendation. So before, this ART part is not a part of indication. Basically what they're saying is that ART is so effective that if someone is on ART, there's no way their CD4 would be less than 50. Or if it is less than 50 and you started ART, it's going to go above 50 very quickly. So if someone is on ART, they don't really need MAC prophylaxis. Now, alternative to macrolides includes rifabutin, basically once a day, and the dose had to be adjusted, if there are agents in the ART that will interfere, or I should say interact with this drug. And we will talk more about these class of rifamycins in general when we talk about tuberculosis. And basically for duration, you can discontinue upon initiation of effective ART. So essentially nobody really needs MAC prophylaxis anymore. Now for prevention of CMV, the DHHS guidelines state that CMV and organ disease is best preventing using ART to maintain a CD4 count of at least 100. In fact, they say that primary prophylaxis, often with valganciclovir, is actually not recommended to prevent CMV and organ disease in people with HIV, even among patients who have CMV viremia. Now, while prevention is not recommended with prophylaxis, it is important to urgently refer patients to ophthalmology if they develop symptoms of retinitis. And in fact, for patients who have a CD4 count of less than 50, it is recommended to have ophthalmologic examination every 3 to 4 months to detect patients who develop retinitis to get them treatment from ophthalmology. The last learning objective is given a patient living with HIV who is infected with an opportunistic infection, recommend guideline-concordant treatment. So for PCP treatment, obviously it's important to start the patient on ART to get the CD4 count up. And then for the actual treatment of PCP, you have to look at the severity. So for mild to moderate, and the criteria are listed here for mild to moderate, you typically use an oral treatment, and again, treatment of choice is Bactrim, so trimsulfa, 15 to 20 milligram, and this dosing is based on the trimethoprim component. So when we say 15 to 20 milligram per kilo per day, that's basically trimethoprim, and then whatever sulfamethoxazole to match it when it comes in the pill. And that's, when you calculate 15 to 20 milligram per day, that's the total daily dose. You want to break it into 3 divided doses. And then you treat the patient for 21 days. And obviously, if they cannot tolerate trimsulfa, you have some alternatives. So dapsone plus trimethoprim, because the sulfamethoxazole typically causes the skin reaction. So if someone cannot tolerate that part, it can also be nephrotoxic. You can give the trimethoprim alone with dapsone. You also have primaquine plus clindamycin, and lastly atovaquone. So atovaquone for prophylaxis is okay, but when it comes to treatment, is an absolute last line, because it is been shown in studies to be less effective. So you really want to avoid atovaquone for treatment if you can. It's only your last option. And then when it comes to moderate to severe, you obviously you want to, if you can, you should use IV treatment. So Bactrim is available as IV, so you can use IV Bactrim. If someone cannot tolerate IV Bactrim, then you have some alternatives. Primaquine obviously is only available as oral, so you have no choice but to give it oral if someone couldn't tolerate pentamidine IV or Bactrim. And for these patients who either the PO2 is less than 70 or the gradient is more than 35, so alveolar and arterial oxygen gradient is greater than 35, these patients also need prednisone. So this is adjunctive. So in addition to what you're giving for treatment, so if you're giving Bactrim, these patients, in addition, they also need prednisone for 21 days. And here's the dosing taper recommendation. And that's because this addition of prednisone has been shown to reduce mortality. So for that reason, someone has moderate to severe PCP, you have to give them prednisone. Or if prednisone is not available, you do an equivalent corticosteroid. And then once you finish treatment, the question is, do you need to prevent this from happening again? So there is such thing as PCP secondary prophylaxis. So you basically give the same agents we use for primary prophylaxis, and you continue it until the CD4 count is greater than 200 for at least 3 months. For Toxoplasma, gondii, encephalitis, the treatment is a combination of pyrimethamine, sulfadiazine, and leucovorin. That's the preferred agent, and you want to treat for at least 6 weeks. So this is a 6-week treatment, and even longer duration if clinical or radiologic disease is extensive or response is incomplete at 6 weeks. So you have to monitor the patient through the 6 weeks and see how they're improving. And then once you finish the treatment, you just continue the same treatment as chronic maintenance therapy, or you can also call this secondary prophylaxis. You just keep continuing the treatment until the patient not only asymptomatic, but you want to make sure the CD4 is more than 200 for at least 6 months. And for disseminated MAC, basically the preferred agent for treatment is combination of clarithromycin with ethambutol. We will discuss ethambutol more when we talk about tuberculosis, but you want at least 2 agents. And many experts also add a 3rd or 4th agent if the mycobacterial load is more than 2 log CFU per ml of blood, or if the patient is not on ART, so you need a 3rd or a 4th agent. And the 3rd and a 4th agent would be rifabutin. This RFB is the shorthand for rifabutin. And you can also use fluoroquinolones, specifically levofloxacin or moxifloxacin, not ciprofloxacin. You can also have the option to use an injectable aminoglycoside. So amikacin and streptomycins are the ones that are typically used, not really gentamicin or tobramycin. The evidence is with amikacin or streptomycin. And then the treatment for MAC is at least 12 months. And then once you finish treatment, you just continue for secondary prophylaxis, or you can call it chronic maintenance therapy, until not only the patient is asymptomatic, but you want to make sure the CD4 is greater than 100 for at least 6 months. Because retinitis is the most common CMV disease, we will focus on managing CMV retinitis. The choice of therapy should be individualized based on tolerance of systemic medications, prior exposure to anti-CMV drugs, as well as on location of lesions in the eye. For example, someone who has been receiving valganciclovir, they may have developed resistance to cyclovir and valganciclovir, so they may need Cidofovir or foscarnet. Now, systemic therapy, either IV or PO, systemic as opposed to intravitreous injection, has been shown to reduce CMV involvement of the contralateral eye, to reduce CMV visceral disease, as well as to improve survival. So the first line therapy includes either IV ganciclovir or PO ganciclovir. Many clinicians prefer the IV formulation when retinitis is more central and sight threatening, or when adequate GI absorption is a concern, so PO cannot be an option. On the other hand, for patients without sight-threatening lesions, oral valganciclovir alone often is adequate. Now, initially, there will be induction therapy, which would last for a minimum of 14 to 21 days, and there is a range, and that will be determined by clinical response based on ophthalmologic examination. And then this will be followed by a maintenance therapy. So during induction therapy, we give a higher doses of these, either ganciclovir or valganciclovir. So there will be higher doses during induction therapy. And then for maintenance therapy, there will be lower doses. And obviously, the primary concern with the high dose during induction therapy would be myelosuppression caused by these agents. And then the maintenance therapy will continue for 3 to 6 months until these patients, while they're taking their ART, they should be able to achieve a CD4 count of at least 100 for 3 to 6 months. And once the lesions are inactive, then maintenance therapy can be discontinued. On the other hand, if the patient's CD4 goes below 100, once somebody has developed CMV retinitis after completion of therapy, if their CD4 goes to less than 100, then chronic maintenance therapy should be reinstituted. Now, alternative therapies include IV foscarnet or IV Cidofovir. It's very rare to use IV Cidofovir because of the complications of dosing and managing nephrotoxicity. For patients that toxicity of ganciclovir or valganciclovir of myelosuppression is a concern, and if those patients do not have renal insufficiency, Or if somebody has ganciclovir resistant CMV, for those patients, IV foscarnet may be used. Now, for patients who have site-threatening lesions, in addition to systemic therapy, it's recommended to also add, in addition, adjunctive intravitreous weekly injections of either ganciclovir or foscarnet in order to achieve enough of the drug, adequate concentrations of the drug in the eyes. So these are the possibilities. So the preferred therapy includes either IV ganciclovir high dose twice a day, for the induction therapy of 14 to 21 days, and then switching to a lower, once a day dosing of IV ganciclovir for maintenance therapy. Alternatively, we can do just the induction therapy of IV ganciclovir and then switching to oral valganciclovir for the maintenance therapy, or for mild cases without site-threatening lesions, the entire regimen could be oral. So twice a day dosing of oral valganciclovir for induction therapy, and then switching to once a day dosing for maintenance therapy. And at any time, regardless of which regimen is used, IV ganciclovir can be switched to oral valganciclovir as long as the patient is clinically improving and there are no concerns about GI absorption. For example, if somebody also have CMV colitis. Now, alternative therapies are listed here, foscarnet and Cidofovir. You can see that, Cidofovir is very, very difficult, so it's, very rarely used. It's hard to find, people who would need Cidofovir, because in cases of resistance, foscarnet would be an option. Now, treatment of other complications of CMV, such as colitis, are similar to retinitis. Obviously, there will be no intravitreous injection for other CMV diseases. This concludes this presentation.